Hello, my name's Penny Rubio. I'm the clinical lead for Tissue Viability, and this video is part of the leg ulcer course, and we are looking today at the fundamentals of compression. So what we're going to cover in this brief session is why compression, why is it needed, how does it work, what sort of compression are we choosing, are we going for full compression or reduced compression, and how are we going to apply this, what modality, and we're going to have a quick look at what bandages, hosiery and nail wraps are available to you. And then I'm just going to offer you a few resources as to where you can go and do some further learning and explore and get some more guidance on how to use these products. Okay, so why compression? Well, we use compression as a treatment for venous leg ulcers and also for chronic edema. You don't have to have a wound on the leg to need compression. So venous disease, really. And there's been a lot of evidence now accumulated to show us that when you have venous disease, venous insufficiency, or you have chronic edema, lymphedema, that actually compression works. It heals leg ulcers and it shifts fluid. So the Cochrane review, they've done a Cochrane review looking at venous leg ulcers and looking at all the different research studies out there, and the evidence is clear that compression does heal venous leg ulcers. So the evidence is there. It is evidence-based treatment. Yeah. Now the issue why it's so important and why you deal with so much of it as district nurses and practice nurses is that actually there are a lot of wounds out there. District nurses have about 50% of your caseload, I believe, is caring for some wound or other, and of those wounds, leg ulcers are by far the most common, and of leg ulcers, venous leg ulcers are by far the most common. So there's a lot of them out there. So you should be using quite a bit of compression in your normal work. Yeah, so compression is the first line treatment for a venous leg ulcer. Okay, so just a little bit about the venous system, and we're going to go and look on and see how compression works for it. So blood is pumped around the body by the heart, and fresh blood goes from the heart via arteries down to all your extremities and all your organs. And it does that under pressure. The heart pumps and you have blood pressure, and the blood is squirted through the arteries under pressure. However, by the time that blood has got down to your toes and your extremities, and it's gone through all sorts of small capillaries, and it's trying to turn the corner and come back uphill again, all of that blood pressure has disappeared, and it's a much harder job to get the blood back up the legs again. So one of the ways that the body helps us to do this is to have a non-return system in the veins, and a series of valves that stop the backflow of blood down the veins. So when we walk and our muscles in our legs, our calf muscles move, they squeeze the veins inside them, and that squirts the blood back up the legs. So it's almost like it is the pumping mechanism for getting blood back up your legs. So heart for the arteries, calf and foot muscles for the veins. That's what pumps things sort of back up. And when the muscles aren't pumping, it's the non-return valves that prevent the blood from flowing backwards when there's no pressure behind it. So things can go wrong with this. So these valves can become incompetent. So you can see in this picture, the valves are not actually meeting. So the blood goes up, but then when there's no compression, no activity of the muscles, and there's no oomph behind it, the blood can fall back down the veins again. So the veins don't close tight. The valves don't close tightly, and the blood leaks back down. Now this can start to cause changes within the legs. So it increases the pressure of the blood in the veins, and then some of the substances in the blood can leak out into the tissues and start to cause issues. And this is the underlying etiology behind venous leg ulcers. So this is known as venous insufficiency, and it results in venous hypertension, high pressure of blood in the veins. So how does compression help this? What does it actually do? Well, it helps venous return in a number of ways. So first and foremost, by putting some compression around the calf muscle, it creates some resistance there. So when you move the calf muscle and the calf muscle contracts, it's unable to expand outwards because it's constrained by the compression, and therefore it increases the pumping around the vessels and gives an almighty squeeze around the veins and really helps pump the blood back up the legs. So it increases increases the calf muscle pump action. Secondly, when the calf muscle is relaxed, it is holding and supporting the leg slightly, and that helps the incompetent valves in the veins to be closer together and to become more competent, so it prevents some of that backflow. And then thirdly, very importantly, compression systems are designed and need to produce a graduated compression. So it's designed to have greater millimeters of mercury, greater compression at the ankle than it has to the calf, than it has to the thigh, so that the overall movement of blood, it's encouraged upwards by the design of the compression. So compression hosiery obviously is shaped to match a leg. Compression bandaging, you may have to shape the leg to achieve that difference in graduation. So it's important that you understand that you need that, and that's a fundamental design as to how compression works. Okay, what's the problem here? There's all sorts of myths and issues going on. You'd think if somebody's got venous disease, easy, compression, we'll just put it on. But there are problems, and there's a number of problems really. One of the key ones is that before you put compression on a leg, you have to check that the arterial supply is adequate, that you're not going to cause any more problems. If somebody's got arterial disease and you put compression bandaging on, it may be that you're going to further inhibit the blood getting down to the toes. So you need to assess the arterial supply, and we do that with a Doppler assessment and a holistic lower limb assessment, and that waiting for that assessment to be completed before you start applying the compression can cause a delay. And sometimes another problem that can happen is that people are anxious about putting full compression on a leg. They think, oh, I don't know, she's quite old, maybe a bit too much. And anyway, maybe some reduced compression will be better and safer for her. This is a complete myth. The whole business of any compression is better than no compression. If somebody has venous disease, they need full compression unless it's going to cause them harm. So a reduced compression is nowhere near as good as full compression. And if your assessment shows that full compression is safe, full compression is what they should be having. Otherwise, you're only half treating the problem. And another problem is that sometimes we struggle with our patients to help them to be concordant with the compression and the care that we're advising. And these three things together have created a situation where people that require compression in many circumstances aren't receiving it. I'd like you to consider a parallel, in my mind, sort of situation. So how many people hear from patients like this patient who's having broken their leg and having a plaster cast put on? How many people hear, oh, please don't put that on so tight, and you've got to make sure I can get my slipper on? That's a common complaint sometimes from patients that we're putting compression on. But if you'd broken your leg and you were going to have a plaster cast put on, would you be saying the same thing? Not so tight, please, and you've got to make sure I can get my slipper on. No, because you know that to heal a bone, the plaster cast has to go on like this, and you accept it. And it's in some ways we need to help our patients understand that actually, you know, we can't put a soft plaster cast on, and if we put it only on the bit above your foot, it's not going to work, and indeed it could cause harm very much. Yes, very much like it would do with a broken bone and a plaster cast. Okay, so there's a lot of evidence out there and a lot of current guidance recognising that more needs to be done in terms of getting compression on people more consistently. We've got to improve on the situation that we've got at the moment, or else people are going to be having these wounds and we're going to be dressing them for months and months on end. So Wounds UK have issued 2 sets of best practice statements around the management of venous leg ulceration. This most recent one in 2019, addressing the complexities of the management of venous leg ulceration, clearly states this, that we need to be doing more with compression. Okay, so as I said before you start compression, we need to be making sure that there is adequate blood supply for the patient to be safe to receive compression. And so we have to complete a holistic lower limb assessment, a holistic vascular assessment of the limb before we do that. So the gold standard assessment is to complete a Doppler to get an ABPI, that's your ankle brachial pressure index. We're not just trying to take those readings and get that figure out of the ABPI, and we also at the same time need to be listening to the sounds of the pulses. There's a lot that you can tell about the state of somebody's arteries by the sounds. If you've got a nice clear triphasic sound to the pulse, you've got some nice elasticated arteries. A very whooshy monophasic sound will tell you that you've got some disease to those arteries already. But we don't take that in isolation. Diabetics, for example, who might have some hardening of the arteries, can have some falsely elevated ABPIs, which might lead you to believe that there's no arterial disease, but it's being masked by the hardening of the arteries. So we always need to back it up with our holistic assessment. So we need to be looking at the signs and symptoms of any arterial and venous disease in the legs. So there's the lower limb assessment form to help you with that, and that's looking at things like temperature, colour, capillary refill, whether you've got signs of claudication, any paling of the limb on elevation, failure to keep the circulation going on elevation, and checking that there are no red flags for ischemia there, that as a result of that assessment you're not getting the picture that this person's got an ischemic limb. And then you're looking at the medical history as well for any signs and symptoms of previous arterial disease, MIs, strokes, or vascular arterial disease surgery, for example, grafts and the like. So putting that whole picture together to decide whether it's safe to apply the compression. So based on those results, as long as your holistic assessment backs up your ABPI result, you would be applying the following compression. So a normal ABPI 1 to 1.3 in the absence of any signs and symptoms of ischemia or arterial disease in the history. 1 to 1.3 is normal, and that person can have high compression therapy as per the formulary. So 40 millimetres of mercury, you'd be safe to put that on. If you've got an ABPI of 0.8 to 1, that suggests that you've got the beginning of some arterial disease, but you've still got adequate circulation to be able to apply high compression to that leg. So you can still put full compression on with an ABPI of 0.8 to 1. You just might think maybe this condition will deteriorate and perhaps I will redoppler them more often than once a year. If it's normal, you do it annually. 0.8 to 1, we would suggest every 6 months to check and see if things have changed. ABPI of 0.6 to 0.8 shows that there is some significant arterial disease. If you're not showing any serious signs of ischemia or claudication pain, you could put reduced compression on this leg at 20 millimetres of mercury and monitor, and we would suggest that you would be redopplering every 3 months there, but at the same time you'd be referring to vascular for more in-depth assessment. And if the ABPI is less than 0.6, we would say it's not safe to put any compression on, excuse me, and you should be referring to tissue viability, and the GP should be referring to the vascular team. Now, an ABPI of more than 1.3, that might suggest that you've got some hardening of the arteries, some calcification of the arteries, which is also a form of arterial disease. It may be that some compression is still safe, but we would suggest that you contact us to discuss that patient first, but this would also be somebody that would need referring to the vascular team. So, compression options, there's more than one way of skinning a cat, and there's more than one way of applying compression onto a leg. The traditional form of compression that we use is bandaging, but in more recent years, hosiery, and particular hosiery kits, have become available, and then also wrap garments. We're going to have a quick look at those now. Not all of them are suitable for all circumstances. So, for example, bandaging, you can't apply that yourself. That's not an easy thing to do. If you were going to be putting some compression on for yourself, you would need to have a stocking or a wrap. However, you wouldn't use a stocking on a very, very wet leg that's highly exuding. So not all forms of compression are suitable for all circumstances, as this chart shows you here. Hosiery. Let's have a quick look at hosiery. Has a bad reputation, hosiery, but actually it is the answer for many, many circumstances. So hosiery kits, which is, they come as 2 stockings together in a box. One is a liner stocking. It's soft, it's easy to get on, it's very stretchy, and it almost acts as a sort of a sliding sock to get the more firm compression stocking on top of the leg. So a liner stocking is 10 millimeters of mercury, and then the second stocking on top is around 30 millimeters of mercury, and that takes the compression level of a hosiery kit up to 40 millimeters of mercury, which is the same as full compression bandaging. And the evidence is that the hosiery kit is just as successful as compression bandaging in healing venous leg ulcers. It's quicker and easier to put on. You need less skill. Patient can do it themselves. So it's our first line of compression for somebody with a venous leg ulcer. You can't, however, put them on a very, very wet leg, so a leg that needs lots of absorbent padding and things underneath it. And there are 2 sorts of hosiery kits. There's a hosiery kit, an Activa one, which is British standard for use in a leg without edema. And then there's the ActiLymph, which is the European standard stocking for use in the leg with edema. Hosiery, you can get it off the peg as well, so that is used either for prevention of disease progression, so if somebody's got varicose veins, venous disease, to try and prevent them from getting a leg ulcer, small, medium, large, extra large and the like, or after somebody has had a venous leg ulcer and you want to prevent them from getting a recurrence. You can use an off-the-peg stocking, again, Activa or ActiLymph, and you can find details of all of these in our hosiery formulary, the Oxfordshire Compression Hosiery Formulary, which you find on our website, on the lower limb tab, and then underneath compression. You'll find that there. You can use off-the-peg hosiery, though only for very mild or moderate chronic edema. If you've got more significant volumes of fluid in the leg or an unusual shaped leg, you will need made-to-measure hosiery. And this is flat knit, it's made of a stiffer fabric, and it will manage the edema better than an off-the-peg stocking. So hosiery, using the formulary, very, very versatile and the most appropriate form of compression in many circumstances. So compression bandages, we will need mainly if you've got a wound that is highly exuding and needs more absorbent dressings underneath, or potentially if you've got a leg that has a lot of edema in it that you need to reduce. So we need to reduce the edema in the leg, and the leg will therefore change shape and size with each application. So we have a number of different bandaging systems. We have bandages that deliver full compression at 40 millimeters of mercury, and we have bandages that deliver reduced compression at 20 millimeters of mercury. So Actico bandages are a short stretch bandage, and they are good for people who have mobility. They create a nice stiff bandaging around the calf, and they really help to increase that calf muscle pump activity. So people who are mobile, able to walk, move their legs, this would be your bandage of choice there. And there are 2 ways of using Actico bandaging, one for a venous leg ulcer, and then also a slightly different technique with the same product for chronic edema. And then there is a different bandage called K2. This is a 2-layer bandage system, has the little rugby balls to footballs circles on it, and the bottom layer of this bandage is a short stretch element, and the top layer of the bandage is a more long stretch. So this is better for people who are more immobile, who don't have as much calf muscle pump, and the long stretch element of the bandage helps produce compression all the time for these people. And there are 2 sizes of that depending upon the ankle circumference. So for all of these bandages, you are going to need a tape measure, because once you've put the wool bandage layer onto the leg, you need to check the ankle circumference to determine either how many layers of bandage you're putting on or which size of bandage you're going to choose. So the Actico, for example, the venous leg ulcer technique, you put a single layer of Actico on for the ankle circumference less than 25 centimetres, but if it's more than 25 centimetres after you've put the wool on, you need a second layer of that bandage from the ankle up. And the K2, there are 2 different sizes of bandage depending upon the ankle circumference, so you have to measure that to make sure that you're getting the right size bandage. And likewise in the reduced compression bandaging section. So if the ankle circumference is less than 25 centimetres, you'll be using Coflex. If it's more than 25 centimetres, the Coflex won't deliver as much as 20 millimetres of mercury, and you'll need to use the K2 reduced bandage, the one that is for ankles greater than 25 centimetres. So really, really important. You have a tape measure and you're measuring that ankle circumference to choose the correct compression bandage. So I just want to say something now about Laplace's law. You may or may not have heard of this. It's an equation that helps us understand what factors it is that goes into resulting in how much compression is applied to a leg with the bandaging system. So the amount of pressure that is exerted is dependent upon 4 different factors. And so this equation sort of addresses all of those. So you don't need to remember the equation at all, but it's the factors that influence the level of pressure that is exerted that we need to understand. So there are 4 factors that can influence the amount of pressure, these are the tension that is applied to the bandage, the number of layers of bandaging that's put on, the size of the limb, so the circumference of the limb, and the width of the bandage. So with the tension put into the bandage, the more tension you put into the bandage, so the more stretch you put into it, the greater that the compression will be put onto a leg. The more layers of bandaging, the more compression. So the bandages can be put on with exactly the same amount of tension, but if you've put a second layer on, or indeed a third or a fourth, you're really increasing the amount of compression that's applied to the limb. Other factors, the circumference of the limb is very important, and we don't do anywhere near enough of carrying tape measures around with us. Anybody who's in compression should have a tape measure in their house so that before you're applying the final compression layers of the bandaging, you can check the ankle circumference to make sure that you're using the right size of bandage and the right number of layers. So the larger the circumference of a leg, the less compression that bandage will put on it. So same bandage, same everything else, same number of layers, same tension and the like, put onto a small ankle will put more compression than onto a larger leg. So you need to know what the circumference of that ankle is before you put the compression on. And then the final thing that influences the amount of pressure applied is the width of the bandage. So a smaller and narrower bandage will put on more compression, and a wider bandage will put on less compression. And this is why when people have chronic edema and we're using the different size bandages in Actico, so 8 centimetre to the foot and ankle, 10 to the lower leg, 12 to the thigh, that is why we do that. We are trying to have that accentuated graduated levels of compression, so more millimeters of mercury right at the bottom of the foot, the leg, when you've got a long way to go up the leg, and then this graduated compression to try and get the blood and the fluid moving up the leg. And you need to bear these things in mind when you're applying compression, because it can, this is why your technique and how you do it is really, really important. So if you're somebody who doesn't take much notice of your 50% overlap, overlap as you're bandaging, and as you're going round the ankle and indeed up the leg, you are doing more than 50% overlap, particularly round the ankle. You can be putting more than the required number of layers of bandage over one part of the ankle and applying more pressure than you should do, and that's not an uncommon thing going around the ankle. And the converse is true. If you're not getting your full 50% overlap and you're just having a slight sort of 1 centimetre overlap in the bandage, you're not going to be getting enough compression put on. If you're not applying the right level of tension, you won't be getting the right compression, and if you're not using the right size bandaging, so say for example you've got quite a large limb that's over 25 centimetres at the ankle and you're only putting one layer of Actico on, you will not be achieving your 40 millimetres of mercury. It will be less than that because the circumference of the leg is bigger. So really important that you take note of those 4 factors and you think about them as you're applying your bandages to work out, are you putting too much or too little or just the right amount of pressure on that limb. So having a look at this picture here, trying to work out what on earth do you think has gone on with this leg here. So this is a very good example. And imagine when you've got this leg dressed, okay? So look at how red and raw that is. You can see there's lots of maceration and excoriation from exudate. So this is clearly looking like it's a very wet area. So imagine that you've got your absorbent pads around that ankle. It only goes up to sort of mid-calf, so you won't need any absorbent pads higher up. And then you've put your pads on, you've put your wool on. What sort of shape are you going to have then? Get your tape measure onto around the ankle now and put that tape measure then around the calf. What do you think is going to be the measurement around the ankle and the measurement around the calf? You need to make sure that the calf is larger by about 10 centimetres than the ankle is after you've got all that padding and wool on, or else when you put the compression on, you haven't got that inverted, graduated sort of shape. It needs to be wider at the top than it is around the ankle so that the compression is pushing the blood up. And we see quite a lot of this. So more tape measures out there, please, and more thinking. I need to make sure that I've shaped the leg with the wool so that it is 10 centimetres wider around the top than it is around the ankle. And here's a really good demonstration of that, really. So a normal shaped leg, you're having a fairly, you can see that the dark blue around the leg is the wool, the padding that you need to be using. So this leg on the left, the normal leg, it's a nice graduated even shape and you don't need much wool. It's the same amount of wool up and down the leg, single layer, winding it on, and you've got a decent shape from it. If on this champagne bottle leg, however, you've got a very narrow ankle and you've got quite a steep gradient either side, and to stop the bandaging from sliding down, you need to pad this out. You've got to have an even graduation, and so you're going to need to use more wool around the ankle to shape that leg properly there. If, and this leg is a little bit like the one sort of below, you've got quite a wide ankle here and you've got a narrower area here, you're going to need more wool at the top than you do at the bottom, although you need a little bit more around this crease here to get that graduated even shape. And here, when you've got a straight up leg, so you know, it's not uncommon for an old person to have very little calf muscles. They have calf muscle wastage, and you've got this drain pipe shaped leg where you need to create that graduated shape with your wool so that you've got the right shape. And it's only when you've got that inverted graduation that you get the blood going up the leg. Oops, excuse me. So that's compression bandaging. So wrap garments, these are brilliant for self-care if people can't get the hosiery on. I would still go for a hosiery kit over wrap garments because the hosiery kit is guaranteed compression. There's no skill. If you've measured it correctly, when you get it on the leg, it's doing the do reliably. With a wrap garment, you still have to have the skill to put it on properly. However, There may be circumstances where a wrap will work better for a patient than hosiery would do. And so we have 2 wraps here for you to choose from. We have the Jobst Faro Wrap 4000, and that is a 2-piece wrap system that has a long sock that goes on the leg first, and it's not just a sock. In the foot and ankle there is some medium compression there. And then but there's none up the leg. So the stocking around the calf, that part of the stocking is quite stretchy and easy to get on, unlike some compression hosiery, but it does put some compression into the foot. And then there is this simple wrap that just goes around the calf, so that there isn't a wrap on the foot. It's all done by the stocking, so it's still easy for people to get their shoes on. And then the wrap goes round the calf, and you put tension in that and stick it down with little Velcro tabs. So you can put this over sort of small to medium dressings, but it's really only suitable for mild edema. If you've got anything more than mild edema, the sock won't cope with it and it will dig in around the ankle. So that's not a wrap for somebody who's got more than just a little puffiness, really. If you're needing a wrap and the person's got edema, then you need the other wrap system, the Juzo ACS Light. Now, do not be fooled by the light. It is not a light wrap. It is intended for people with chronic edema, large legs. This is the wrap that an lymphedema clinic use. So I don't know why it's called light, but it is not a light compression. It is full compression if it's put on properly. So ACS stands for Adjustable Compression System. And this comes in a number of different wrap garments. So this is the foot wrap you can see here. This is the calf wrap, but there is also a knee and thigh option to this. So you could have full length thigh compression in different wraps. This is good for reducing and maintaining edema. It's good for reducing edema because as the leg gets smaller, you can just put the wrap on more firmly. It's also good for patients themselves to reduce edema, because if they put the wrap on in the, as soon as the wrap is sort of put on, the fluid should start to move and the edema will start to shrink and the leg will begin to get smaller. So the wrap can be tightened, and so it's a good way of reducing edema in a limb when there isn't anybody available with any skill at chronic edema bandaging to reduce the edema in a limb. So we've used this fairly successfully in community hospitals before now to reduce the size of a leg. And then, of course, once the edema is moved, it can still be used as a maintenance garment as well. Okay, so just a word now about compression for toes, because it's not just legs that can get edema. Sometimes people with chronic edema, it does go right into their toes, and you have toes like little sausages, have what we call the positive stemmer sign. So when you try and pinch a skin fold at the base of the second toe, you can't, because there's so much edema in the toe. So if you've got edema in the toes, you need to manage that, because toes can ulcerate too, and ignore it at your peril, because once toes start to weep, they can be very difficult to heal. We do use compression round toes, but it would be generally stump bandaging that we would use. So we would be using the Actico bandage in the chronic edema application technique, and then we would be putting wool around the toes and making a sort of a stump bandage, a toe stump, with that bandaging over the top, so that you've got dressings underneath it and it would hold it all in place. So using something to manage the edema in the toes before it breaks down is strongly recommended. And these great little garments, the Haddon and microfine toe cap, they're like little fingerless elasticated sort of stockings for the toes, are a brilliant option. So these are off the peg, so you just have to measure the circumference of the foot around the ball of the foot, so around that bunion area, get your tape measure around that area, and depending upon that circumference measurement around here, you'll be a small, medium, large, extra large. and then you ask the GP to prescribe that on FP10. These can go under bandages, so if you're needing to bandage the leg because of ulceration or something, or to decongest the leg, you can put these on the toes first and then you put the bandaging on top. You just need to remember to put them on inside out so that all the seams and the labels are on the outside. And also when they first come, they are made so that they will fit any foot length. So somebody a size 14 as well as a size 3, which might mean that you need to get a pair of scissors to them to cut them down if the person's got quite a small foot. So they cut no problems, and generally you need to cut at least an inch off the length of them, I find. So you need to sort of, cut it off here. And then this is about the right length for these garments. Sometimes you see them sort of cut down to below the toenail. That is too short. They can slide down the toes and sort of gather and rock up around the bottom of the toes here. The actual toe bit needs to be cut so that it's the same length as the toe, so you're literally just seeing the tip of the toe out there. And then they're washable, they go in the washing machine and the like. So you'd have 2 for each foot, one on, one in the wash, basically.